So we are talking about the topic on mantle cell lymphoma, which is a rare form of non-Hodgkin's lymphoma, about 6%. But in the US each year, there's about 4,000 people diagnosed. Because we are able to prolong people's lives, so the prevalence is much more than 4,000 people, it's much higher. So for people who don't know mantle cell lymphoma, it may be a rare topic, but for the patients and the families who are affected by this dangerous disease, life-threatening disease, it's a huge deal. So when a patient are young, when they're diagnosed with mantle cell lymphoma, we are able to give them intensive chemotherapies. This survival over 10 years, all the intensive therapies. However, in elderly people, especially when their age is over 65, they're not able to tolerate intensive chemotherapy like the young people do. So their survival is only about 5 years. So there's a big discrepancy between the people less than 65 or older than 65. In order to close this gap, we did this SHINE clinical trial. The standard therapy for this population, for the elderly population with newly diagnosed mantle cell lymphoma, are usually treated by bendamustine-rituximab. And this has a failure-free survival about, at the best, 3.5 years. So, and their overall survival is about 5 years. So how do we in this clinical trial, we did a phase 3 clinical trial. The one arm is the ibrutinib with the standard bendamustine-rituximab, we call it the BR. So ibrutinib with the BR. On the other arm is placebo plus BR. So we are able to see the difference that ibrutinib could make in this population. So it's an international study, gigantic international study, including 183 the world's best hospitals in 28 countries, almost in every continent. There's patients enrolled on this study. And the study was designed 10 years ago. And I had the fortune to lead the scientific steering committee to design this study with many colleagues in Europe and in America. And so we started the enrollment in the trial about 10 years ago. Actually, about 3 years later, so we enrolled 523 patients. So 2 arms, right? So the study, the endpoint for the study is progression-free survival. So from the start of the therapy until the patient has a progression or died from something, that's the time we're talking about. This is a consensus defined endpoint approved by FDA and all the regulatory agencies, the EMA, and we all recognize PFS. Why? Because if we do overall survival, which is the golden standard, in this clinical trial, it would take 1,000 to 2,000 patients over 15 to 20 years. And our patient cannot wait that long. So we use a surrogate marker called progression-free survival. So in this progression-free survival, the study is a huge, stunning success. It's very significant. So with the ibrutinib arm, the expanded arm, the PFS was 6.7 years. And with the placebo arm, the median was PFS was 4.4 years. So there's a 2.3-year gain over the control arm. This gain is very meaningful to our patients, okay? Suppose we have a patient who are 71 years old. They come to my clinic to see Dr. Wang. I want to get therapy from you. I said, okay, we'll give you the therapy. If I give them the ibrutinib and BR, they have 6.7 years. They don't need any other therapy. They do not have, and then they probably will went on to live over 10 years when their age is 81. So we want to, in my opinion, I've been treating mantle cell lymphoma for 20 years. In my opinion, the first therapy is the most important therapy for mantle cell lymphoma. Why? Because at that time, the patient's resources are still intact. Whatever therapy you give them, the response is going to be higher, and the duration will last longer, and they are able to tolerate the side effects much better than later, right? So you give them the first therapy, you hope the duration lasts as long as possible. 10 years later, we'll figure something else out for this patient. So this is a very positive study. in my opinion, is going to change the current standard of care, and it is really great news for our patients and families. I want to thank all the patients and their families, their determination, their bravery, and their hard work, and it made this trial all possible. We looked at also the toxicities, and obviously the toxicities occurred more in the experimental arm with ibrutinib, less in the placebo arm. For example, the rash and pneumonia happens 10% higher in the ibrutinib arm than the placebo arm. But when we designed the study 10 years ago, we were at the start of using BTK inhibitors. After 10 years, we have evolved. We know exactly how to handle the side effects. So we are much more comfortable and more effective in handling the side effects. So also the other side effects like anemia and also the diarrhea occurs a little more than in the ibrutinib arm than the placebo arm. We know how to handle those side effects. And we will also look at the overall response rate. The overall response rate is about 90% in each arm. The complete response rate is 65% in the ibrutinib arm versus only 57% in the placebo arm. So the CR rate is much higher than the placebo arm.